So here we are at Helicobacter pylori. I told you before that I had some concerns about the way it's a commensal organism. I'd say it's generally a commensal organism, but it can become a pathobiont later in life. And Martin Blazer, the researcher at NYU, he has called in his book, which is entitled Missing Microbes. I highly recommend it if you haven't read it. He suggests that H. pylori is the central organism in the gastrobiome. We have a microbiome in the colon, small intestine. We have another one in the stomach. There's one in the esophagus. There's one in the mouth. And the gastrobiome, specifically the bacteria and other organisms that live in the stomach. And in his book, he talks about it as the central organism in that gastrobiome, one of the ancient dominion organisms, meaning one that is rapidly being lost, one of the missing microbes. Now, H. pylori often is thought of as an organism that leads to excessive acid production, hyperchlorhydria. But I just want to point out that the research shows that initially, when H. pylori colonizes in the stomach, it causes hypochlorhydria almost universally for the first 3 months. After that, it depends on its location. So there's often a gastritis that sets up with H. pylori. We don't know if that gastritis is actually beneficial or problematic, but that gastritis can be antral focused, or it can be the entire stomach, pangastritis. When it's antral focused, there the patient actually is going to end up with hyperchlorhydria. Whereas if it's a pangastritis, they're going to end up with hypochlorhydria. Very rarely achlorhydria. That's really usually more associated with autoimmune gastritis. And then some patients are just going to have it as a commensal and have normal stomach acid, euchlorhydria. So they'd be asymptomatic. There's a lot of evidence for H. pylori being a human commensal. All mammals have a Helicobacter species in their stomachs. For instance, pigs have Helicobacter sui, and there's another one for cetaceans, whales, and other marine life. So it's been found that virtually every mammal on Earth has an H. Helicobacter in their stomach, and Helicobacter pylori is just the human species. And it's thought that the H. pylori has been in the human stomach for close to 60,000 years, maybe longer, and it's worldwide. And the thought is that until the 1930s and 40s and beyond, we're now on our 5th generation of people raised with antibiotics, maybe already on the 6th. Until then, 100% of the population of the world had H. pylori in their stomach. And it was there for a purpose as a commensal, especially for the developing child, to develop the immune system in the gut. We know that there are 4 well-proven H. pylori associated diseases where H. pylori can become a pathobiont and cause disease. There's peptic ulcer disease, duodenal or gastric ulcer. There's atrophic gastritis. There's intestinal type gastric adenocarcinoma. And there's a rare form of lymphoma called maltoma for mucosal associated lymphatic tissue that occurs in the stomach. All of these can be associated with H. pylori. So what's the deal? Is it a pathogen or is it protective? The thing is that the declining numbers of people that have H. pylori as a commensal in their stomach is thought to be a risk factor for refractory GERD that doesn't respond to standard treatments, and the complications of reflux, including Barrett's esophagus and cancer of the esophagus. I made this little graphic here to show how the different locations make a difference in the risk factors. So with H. pylori antral predominant gastritis on the bottom here, we're more likely to have hyperchlorhydria, peptic ulcer disease, stomach or duodenum, and again, antral focused here. The issue is that the parietal cells are in the body of the stomach. And if the body of the stomach is not affected by the H. pylori, the stomach parietal cells can respond and they can make acid. And if there's antral gastritis, that inflammation in the antrum can stimulate the G cells to make more gastrin, and then the gastrin raises the activity. It's a neuropeptide that is a stimulator of gastric acid production. And so these folks tend to have hyperchlorhydria. On the other hand, pangastritis, shown at the top here, instead of increasing the risk for peptic ulcer disease, could really be the factor that increases the risk of cancer of the stomach and maybe cancer in the mucosa-associated lymphatic tissue as well. But at the same time, they're going to have a decreased risk for reflux, Barrett's esophagus, and esophageal cancer. These are the folks that have more risk of getting stomach cancer, even though it's a very small percentage, but it is there. And they're going to have a tendency toward hypochlorhydria because the entire stomach has inflammation, and the parietal cells in the body of the stomach are going to be affected, and they may not be able to make gastric acid. These are some of the studies that have looked at inverse associations between H. pylori and disease. And I mentioned already the GERD and the Barrett's esophagus and esophageal cancer. But also, having H. pylori in the stomach at an early age reduces the risk of asthma, eczema, allergic rhinitis, all the allergic triad conditions. I think it also decreases the risk of eosinophilic esophagitis. But that's just a hunch that I have. There's some studies that it's mixed, that cardiovascular events, especially fatal cardiovascular events, may be reduced. There are studies that show that cancer of the larynx can be reduced. And again, with laryngopharyngeal reflux reduction, you're probably going to have less of that irritation to the larynx. Crohn's disease, there's a meta-analysis showing that Crohn's disease risk is reduced if H. pylori is present. And then obesity and even tuberculosis, the risks are higher if H. pylori is not in the stomach. The standard lab testing for H. pylori includes a serum IgG antibody, a breath test, which is a urease-based test where urea gets broken down and is exhaled in the exhaled air, and then a stool antigen. And I'll mention that both the breath test and the stool antigen are excellent tests if you plan to test again after treatment, because they will change when the organism is no longer present. The stool antigen and the breath test will normalize, although the serum antibody may persist for some period of time, and so not as good for repeat testing. There are a couple of non-standard tests that you'll see with functional lab testing, and that's DNA for H. pylori in the stool and a salivary IgG as opposed to the serum IgG. And these tests can be used as screening tests, but I would suggest that if you do these, follow them with a standard test before you consider treatment. Then again, the reason that I'm concerned about this is I think natural doctors, functional medicine doctors, even everybody who practices medicine, I think can get it wrong. And that is if you use the test, remember I said on my stool testing, I don't like to use labs that automatically include H. pylori testing on a stool test or any other type of testing. And that's because I don't want to find commensal H. pylori. If my patient doesn't have recognizable conditions that are related to H. pylori that would make me want to treat it, I don't even want to know if they have it, because if it's commensal, I don't want to have to treat them. And the standard dictum in H. pylori is test and treat, meaning if you test them and it's positive, you're supposed to treat them. You can't say, oh, that's just commensal, I'm going to leave that alone. You could, but it's frowned upon. So I think this is especially important for the pediatric population that gets the most benefit at maturing their digestive tract and the immune system in their digestive tract by having H. pylori as a commensal. So if you are going to eradicate H. pylori, there are the standard triple and even quadruple therapies. I do find that the research seems to show that a number of things can make standard triple therapy more effective. One would be to add a probiotic, and that could be Saccharomyces boulardii or a lactobacillus type probiotic during the treatment, and also to reduce side effects. The second would be lactoferrin, which is a defensin that can be taken as a supplement in a capsule, and it's part of what you would find in mother's milk during the first few days as well, but it's a very protective factor and it helps with viral and bacterial control. So taking anywhere from 300 to 900 milligrams of lactoferrin each day that they're on the triple therapy can also improve the effectiveness of triple therapy. And the third thing is to consider a low nickel diet, because nickel is shown to be a cofactor for the urease enzyme that H. pylori uses to do most of its metabolic work. And so a nickel-free diet during the 10 to 14 days of treatment could also help to reduce the viability of the organism and make it more susceptible to treatment. I've just listed some benefits of therapy. I do want to point out here that if your patient has maltoma, that rare form of gastric lymphoma, and then you really have to test them for H. pylori. These are patients that should always be tested. And if they have both, treating the H. pylori can just virtually melt the tumor. This is one of the rare types of cancer that can be treated with antibiotics. It's remarkable, 84% cure rate. I also want to mention that idiopathic thrombocytopenic purpura, iron deficiency anemia with no other known cause, recurrent chronic urticaria, and psoriasis. If your patient also is positive for H. pylori, treating it can really be a game changer.